Hello, this is my run chart presentation. My case scenario is that I am a master's prepared nurse that is leading a quality improvement project in an urban hospital's emergency department. The team aims to reduce the median length of stay for patients with low acuity conditions such as headaches, stomach aches, and sore throats. The team collected data on the median length of stay in minutes for patient population over a 20-week period. After 8 weeks, the ED implemented a fast-track protocol for low acuity patients, diverting them to a separate area with a dedicated provider. My plan do study act cycle is plan to reduce the length of stay for low acuity patients by 30 minutes over the next 20 weeks. We will do this by educating the triage nurses about and implementing the triage assessment tool, which will help us determine which patients are appropriate for the fast track protocol. Patients who triage as a green would be most appropriate for the fast track dedicated provider. These individuals are having, like I said, headaches, sore throat, runny noses, or may just need refills on medications, but they don't have a primary care provider that they can get into to get that done in a timely manner. The triage tool intervention is how when a patient is triaged, they are either considered red, yellow, green, or black. Black is deceased. Red is the patient requires immediate treatment, such as they've attempted suicide via poisoning, or they are the most critical, and so they need attention first. Yellow is that the patient is stable at the moment and is not in immediate danger, but that can change, and so they will require observation. Green, this is what we consider a walkie-talkie. So they don't need immediate attention, or it's not an urgent situation to where they need immediate care. And here are the results for the data that was collected. Prior to the intervention, we were averaging greater than 90 minutes each week for the length of stay. After the intervention of the triage assessment tool and the fast track protocol, we saw a significant drop at week 9 down to 78 minutes for the length of stay. Starting week 10, we were at or below the average of 75 minutes, with our shortest length of stay being during week 13, which was just over an hour at 65 minutes. From our highest to our lowest, to the lowest length of wait times, there was a 34-minute decrease in length of stay for the low acuity patients that presented to the emergency department. Rules of a run chart. Rules of a shift is 6 or more consecutive data points without being equal to the median, which we only experienced early on in the study, where we had 9 consecutive points above the median. Rule of a trend, which is 5 or more consecutive data points, all going up or down. We experienced this starting week 7 to week 11 after the intervention, which showed consistent improvement towards lesser time spent in the emergency department. Rule of too many or too few, which is a run of 1 or more consecutive data points on the same side of the median. We had a run of 9 above the median and after the intervention, we had a run of 11 below the median. And then the rule of astronomical data point looks for any outliers in the data, which we did not have any with this data set. Quality implications for reducing the length of stay for low acuity patients in the emergency department. Having low acuity patients see the fast-tracked provider will help improve outcomes for all patients in the emergency room. These individuals will be able to be seen sooner and receive quality care from a provider who is focused on them. It will also allow for true emergencies to be seen in a proper amount of time and also have focus on them without interruptions from a less urgent matter. The fast track also helps alleviate wait times and decrease congestion in the waiting room, creating a better environment when emotions can already be high. Having extended lengths of stay increases the risk of being admitted, and having shorter lengths of stay improves patient satisfaction scores, and having the fast track provider will help reduce the number of patients that leave the emergency department before they are able to be seen by a physician. Just some reflections. Both the Plan, Do, Study, Act, and Model for Improvement quality tools were both ideal for this data set and the goal that was put in place. For the Fast Track ED project, using the PDSA tool, I was able to understand the problem and the cause for the gap in quality, as well as collect baseline data and establish an objective. The model for improvement allowed me to know when the change showed improvement, as well as the change that needs to be made in order to support the data set. Limitation with this study was that we collected only 20 weeks of data. A true conclusion could be drawn after study was completed for 1 year. There are a lot of factors that go into wait times within the ED, such as holidays or the weather changes, people coming in to cool off from the extreme heat, or the homeless population, or anyone for that matter that has been exposed to excessive heat and they're either having heat exhaustion or heat stroke. And then also the extreme cold, people who are outside for an extended period of time, getting frostbite or just exposure to extreme cold for extended periods of time. Another big one that a lot of people don't think about is July 1st is when the new residents start within teaching hospitals. So this could, and usually does, cause a major delay in how fast care is received. I found this project interesting even though the scenario does not relate directly to my line of work, but it does indirectly. We receive majority of our admissions on the inpatient side from the emergency department. And if things are delayed in the ED, then the patient can be delayed arriving to the floor, and it just causes a domino effect with care. Also, I have experienced the fast track personally, and it was quite nice being seen almost immediately after being triaged and not having to sit in the waiting room and wait for hours for a physician to come see me once I was in the room. And those are my references. Thank you.